Hello, my name is Jacob Hartman. I'm recording my full body head to toe assessment for Azusa Pacific University. Thanks. Hello, my name is Jacob. I'm going to be your nurse today. It's nice to meet you.
Nice to meet you.
Nice to meet you. Now I'm going to wash my hands, ensure some patient privacy, close the curtains so that no one can see into the room. How are you doing today? What's your name, sir?
I'm doing fine, Anthony.
Anthony, and what's your date of birth, Anthony?
8/18/1997.
Awesome. And can I just see your wristband to confirm your
Yes,
identity
of course,
here?
of course.
Awesome. Any allergies or anything?
No
You
allergies.
need to let us know about? Okay,
No.
awesome. Now here I'm going to take the patient's vital signs, some of the general vitals. Blood pressure is just going to be 120/80. Pulse is going to be 60. Normal range 60 to 80. Temperature is 98.6. OSAT is 98% on room air. His respirations are about 16 per minute, all within normal ranges, stating pain on a scale of 10 as a 3. Now I'm going to move on to the general survey. So how are you doing? What brings you in today?
Just doing a general assessment here.
General assessment,
Yeah,
okay.
so-
At this point, I'm going to inspect certain parts of him. He's dressed appropriately for the weather. He seems to be regularly developed, adequate sexual development for his stated age, 23-year-old male. Generally fit, decent fat to body weight ratio. Height is overall normal. He's got a cool gold chain. Is hygienic. Speech is completely normal from the interaction so far. So what is it today that you're wanting to have done? Is it a regular physical?
Yeah, I'm just looking for a regular physical. Nothing too specific
Okay,
here.
awesome. Here we're going to move on to the mental status. And the mental status, the patient is following the ABCT system, completely aware. His appearance is normal, again, dressed adequately for the weather. His behavior is polite, mannered. His posture is good. His cognition is normal. I'm just going to do a basic mental assessment here. So I'm just going to ask you to respond or to remember a few words for me here.
Sure.
I'm going to ask you to remember cat,
Cool.
dog,
Okay.
fish, dragon. Okay?
Okay.
Just remember those 4 words, and I'm going to ask you a couple
Got it.
questions. Who is our president?
Trump.
Donald Trump. Okay, good. And what's the date today?
Today is the 15th, I believe, of December in 2020.
2020. Awesome. And where are you today?
I am in Riverside.
Riverside.
today.
Okay. And what is the location you're at right now?
Just a hospital.
Hospital. Okay.
Hospital.
And what were those 4 words I asked you to remember?
Oh man, geez, you asked me for dog, cat, fish, and dragon.
Okay. Awesome.
those
Awesome.
ones.
That is good. Okay. So now we're going to move on to the most basic aspects of the assessment, starting with the cranial nerves. So first we're going to test cranial nerve 1, which is the olfactory cranial nerve. So sir, I'm going to ask you to do some things for me here. First we're going to test your sense of smell. So I'm going to wave something under him and see if he can assess and figure out what that is.
Sardines?
It's sardines, so he does have a good sense of smell.
Wow.
We're going to skip part 2, or cranial nerve 2, because cranial nerve 2 is going to be the eyes, which was my drawn assessment, so we're going to focus on that later on. Cranial nerve 3, 4, and 6, we're going to assess with the cardinal motions test. So if you would stand up and
Of course.
do this here, face me. So I'm gonna do some motions here, and you can feel free to move around the room or whatever. You're just gonna follow my fingers with your eyes without moving your head, okay? All right, so cranial nerves 3, 4, and 6 are all intact. Up next, we're going to test cranial nerve 5, so you can sit back down.
Perfect.
For this one, there's both a sensory and a motor function. So first, we're going to test the motor. So I'm going to ask you to try to close your jaw while I pull down on it. That's good. So sensory, or the motor function of 5 is intact. Next, I'm going to do the sensory. So I'm going to touch your face a little bit. When I do, you're just going to tell me when you feel it, okay?
Hey, I feel that.
Okay, good.
Oh, felt that. Oh, yep.
Okay, good. So sensory of cranial 5 is intact as well. Up next, we're going to do cranial nerve 7, the facial cranial nerve. So you're just going to make some facial expressions at me. So go ahead and smile. All right, now frown. Now raise your eyebrows real high. Now I want you to just puff your cheeks out big for me. And everything is normal. Cranial 7 is fine. Next, we're going to test cranial nerve 8. So I want you to cover this ear with your hand for me. And I'm going to whisper something behind you. Just tell me what it is that I whisper.
Uh-huh. Oh, poo-poo, I believe is what you said.
Good, that's good. So
Okay.
cranial nerve 8 is intact. We can test that on both sides. Up next is 9 and 10. I don't have gloves or a presser, so I'm not going to put my fingers in his mouth, but I would generally put a tongue depressor onto his tongue to test his gag reflex. If it responded normally, then cranial nerves 9 and 10 would be intact. Up next is 11. I'm going to put some weight on your shoulders. I'm just
Sure.
going to ask you to try to lift them up against me. All right, that's pretty good. Now I'm going to put this on your face. Just turn your hand toward my hand.
Mm-hmm.
Okay, normal. And now again.
Mm-hmm.
So cranial nerve 11 is intact. Now for 12, just stick your tongue out for me.
Uh-huh.
All right, and cranial nerve 12 is responsive. All of his cranial nerves are intact as tested, except for 2 again, which we will get to later. Now, camera, if you would like to come over here, we're going to get a little more touchy. So now we're going to test the lymph nodes of the patient, starting with the pre-auricular on the front side of the ears here. We're going to move around. Then we're going to the post-auricular, just behind. Then we're going to go to the occipital, toward the back of the head. Then the submental, under the chin, followed by the submandibular, underneath the mandible joint. Then we're going to go to the jugulodigastric on the bottom of the ears, feel around there. Then we're going to do the cervical, which is the down the neck points. First the superficial, then the then the deep cervical, then the post-cervical lymph nodes. Followed last with the supraclavicular on the inside of the clavicles. All of the, and you can return to the seated location. All the lymph nodes are normal and within reason. Up next, we go to the thorax and lungs. In the thorax and lungs, first we're going to inspect, make sure that everything is normal. Doesn't appear to have any barrel chesting. His respiration rate is normal, as was previously stated. There is no effort or labored breathing, and it doesn't appear to be any adventitious muscles used. We're seeing no breath from his stomach to get complete unlabored breaths. So first we're going to, upon inspection, then start to look at the diameter. As we can see, there's no barrel chesting. I'll ask you to turn to your side here, Mr. Patient. We're going to place our hands at the base of the lungs and anterior to where the diaphragm would be, and ask you to make a postured full breath deep. And out. His chest expansion is symmetrical. Transverse diameter is 1-to-1 bilaterally. And he appears to have normal breathing. Now from here, we're going to take the stethoscope and listen in for any inconsistencies, irregularities, or problems breathing, just with the main side of our stethoscope. We want to move symmetrically. 1 full breath. And out. All right, again. Out. In. Out. In. Out. In. Out. In. Out. Now we'll ask you to turn the other direction. And there's no crackling, wheezing, or coarse sounds being heard through the stethoscope. We're then going to do the same thing, starting at the top, and again moving symmetrically. In. Out. In. Out. In. Out. In. Out. In. Out. In. Out. And we do that in 6 symmetrical positions. Again, no adventitious breathing is being used for this, and there are no coarse crackles or anything of that nature being heard. No irregularities in the symmetry, and the lungs were symmetrical throughout. Now we're going to move on to the cardiovascular system. We're going to start with the neck vessels. First, using what would be a tangential light, but we do not have one on hand. We would be looking for any JVD, or jugular vein distension, where the actual jugular vein here would be distending. It is completely normal. From here, we're going to palpate the carotid artery and then listen in for any bruit. Bruit is a common problem where we hear some air in the arteries. So we're going to take the bell end of our stethoscope and listen in. No bruit is heard. So he is, at least in that regard, healthy.
Good to be one.
Good to be one. We then move on to inspecting further down in the precordium. When we're at the precordium, what we're going to do is we're going to look for any thrills or extensions, distensions, or swelling here. The chest looks completely normal, so we're then going to jump to the valves. I'm skipping something. Yeah, that's fine. So we're then going to listen to the 4 valves. The 4 valves that we're going to be focusing on here are going to be the pulmonic, which is located here in auscultation, just to the right of the sternum, followed by the aortic, then the pulmonic, then the tricuspid, followed by the mitral valve. You're going to listen in for all of them to ensure with both the main stethoscope piece and the bell, that there are no issues and that you can hear the valves opening and closing. You're going to listen for any problems with the S1 and S2 nodes. If there's a murmur present, then you will have to listen for a full minute on the patient. But if there are no murmurs present, then everything is, for the most part, seemingly healthy with the cardiovascular system. Then we're going to move on to the peripheral vascular system. Starting at the shoulders, you're going to be looking for any inconsistencies, things like edema, discoloration. You'd see some clubbing, any clubbing. You're going to be noticing cyanosis, jaundice if the patient has any issues with jaundice, pallor. You're going to test the turgor again. Make sure that weight distribution is even. Any swelling and edema would be problematic. As you move down, you'll be able to test at the fingertips any of the clubbing that may be present there. And you want to check cap refill is less than 2 seconds. If you are moving down the arm, you're also able to check the 3 separate pulse points. You're going to want to check the brachial, the ulnar, and the radial pulse points, top to bottom. Moving forward, we're going to do peripheral vascular for the lower body. At the lower body, a few more things that you want to check out: still, color, edema, any varicosities. If there is any DVT present or deep vein thrombosis, you want to be aware and note that. They may be requiring certain lab results and tests specifically. You will check all of the pulse points here. It's going to be the femoral, the popliteal, the dorsal, and the pedis on the way down, as well checking cap refill at the feet for ensuring that they have proper circulation, especially with diabetic patients and peripheral neuropathy. It's an important consideration to ensure that peripheral vascular systems are functioning regularly. Moving on, we're going to get to the abdomen. So, oh, that's what I forgot. I forgot to have you lay down. We're going to move back to cardiovascular because we were supposed to, no, we won't. Go. We're going to move to the abdomen. For the abdomen, and then for a little bit of the supine of the cardiovascular. The abdomen, you're going to start off with inspection. Is it okay if I pull your shirt up a little bit, sir? You can say no. It's really up to you.
Is it okay if I do it?
Yeah, no, that's fine.
Yeah.
Of course. Yeah. So first, with the abdomen, you're going to want to inspect to make sure that there are no irregularities. Again, any organ megaly that's visible, or any swelling, edema, etc. You're first going to inspect across to make sure there's no discoloration or problematic areas to focus on. Then after that, you're going to auscultate second, which is irregular from most of the normal focusing, but you want to listen in first for normal bowel sounds. If you hear no bowel sounds, you'll want to listen for a full 5 minutes to ensure that there are no bowel sounds. So we'll listen in. Might hear bowel sounds pretty quickly. Good one. Then with the bell end of my stethoscope, I'm going to listen for any bruit that may be present within the bowels. I hear no whooshing. I hear no whooshing, so bruit is not present. From there, we're going to do percussion on all 4 of the quadrants, just minor percussion to ensure that it's resonant. And then we'll do 2 separate kinds of palpation. Primary palpation is going to be a light touch, just to test for any CVA tenderness, any pain upon touch, especially with patients who have things like appendicitis. Even light touching is going to be very problematic, and it can be an indicator for a number of different conditions. If they are able to withstand the light touch, then you're going to want to use a deeper palpation. That's going to test if you have swollen organs, if there's any irregularities or clotting that may have occurred. So you just want to feel around to ensure that there's no organic problems within the bowels. Moving past the abdomen. Come on, sir.
Okay.
Oh, that was good. That was good. Now we're going to move on to the neurological assessment. You can switch on back. What's the time at right now? 14? God, I'm slow. Moving on to the neurological assessment. First, we're going to focus on, if you could stand up. Oh, you are fine. We're first going to focus on the finger-to-finger test. So you're going to want to put your finger to your nose and then touch it to mine in different places, okay? Good. Now back. Good. Good. Awesome. Good. Wonderful. Great. So this positive finger test did very well. Next, we're going to do the Romberg test. So you're going to want to face forward, close your eyes, put your hands on your sides. And we're going to hold this for 20 seconds generally, just because of the video format. We're going to skip that. He has a negative Romberg test, does not sway side to side, balance and control of motion are intact. Then we're going to have you sit down. Up next, we would test a superficial pain sensation on the spinal tract. For here, if I had a sharp tool with a dull side, let's say for instance, I would use this tape here. Has a sharp and a dull side. Tell me what this feels like.
Oh, it felt a little bit like the sharp side.
Okay.
The dull side.
Okay.
The sharp side.
Okay.
Dull side. Ooh, sharp side.
All right, so superficial pain sensation is intact. After that, we're going to focus on the dermatones. The dermatones that are present in the spinal column are as follows. Thumb, middle finger, and pinky finger are C6, C7, C8. The axilla, nipple, and the umbilica are T1, 4, and 10, respectively. And the groin and the knee are L1 and L4. These are the primary dermatones to be tested. Now we're going to test the deep tendon reflexes. For the sake of this, we're only going to be following the tricep, the bicep, the knee, and the Achilles. For the tricep, we're going to leave an L-shaped motion outward, and with a reflex hammer, and smack here to see a reactive action. Then from the inside, I would get the inner bicep, which should have a natural pulling reaction. Then I would straighten up the knee and hit right above to get a general kick, and then cross the Achilles over, pull the foot flat, and hammer the backside right above the ankle. That's the general assessment for the nerve testing that is required. Now for the final portion of the test is my section that was pulled specifically for this, which is the eyes. For the eyes, if you'd like to stand up, it always starts with a vision acuity test. Vision acuity is normally done through the Snellen's chart. So I would ask my patient to try to read something about 15 to 20 feet away. What's the furthest line down that he can read? In an ideal setting, he has a vision of roughly 20/20. How can you read what is at a distance?
Yeah.
Oh, he has 20/20 vision.
Wow.
This patient is a perfect physical specimen. Now, because this patient is not over 40, I would not administer this next test, but for the testing circumstances I will. I would hand him, and this is blank, a piece of paper about 14 inches from his face and ask him to read the furthest line down that he can. Similar to the Snellen's chart, it should specifically state what is and isn't passable vision for a healthy individual. He can read 20/20 at this distance as well. Things are completely normal. He's a healthy guy. Up next, I'm going to focus on the actual eye exam itself, so if you'd like to face me. Yeah, just on the edges, so you can turn this. So with the eye, first off, we're going to inspect again. We want to look at the actual eye above, focusing on the lid. We want to see if there's any ptosis, any sag, any exophthalmos or enophthalmos. He doesn't appear to have any. Then we'll go down to the lids. We want to see if there's any entropion, ectropion, any lid sag or lid bagging. Appears to be normal and fine. We'll move on to the conjunctiva. If we lift above, the conjunctiva has no hemorrhaging, no injection, and is normal. Then we'll focus on the sclera. The color is china white, consistent with ethnic background. Clearly, perfect half Peruvian individual. Then, after that, we'll focus on the pupils themselves, or we'll focus on perla, which is really a pupil test with minor light, which we would have in the center. We would test for the equal roundness of the pupils themselves, the reaction that they have to light coming in and going out, as well as the accommodation that they have. If I move my finger in, does the pupil naturally react to it? Yes, so perla is good and positive. Patient is completely functional and regular. In terms of eye, he has 20/20 vision. Last thing we would do is the fundoscopic exam with the ophthalmoscope. We obviously do not have an ophthalmoscope, but generally the process for the ophthalmoscope would be that I open the eye and come in at about a 15-degree angle with my finger on the actual notch itself and point inward, looking for his optic disc, the vessels within. The coloration of the optic disc is a normal orangish red, and there are no dysfunctional features within the eye. He will pass the red test, I forget the name of, but there should be a red test based on the inside of the optic disc there. After that's done, I would then turn the light off, make sure that his accommodation of light is normal and his pupils are undilated properly. And then I would start to say thank you and my goodbyes to this lovely patient. I would shake his hand and say, hey, thank you so much for letting me be your nurse. After shaking his hand, I would wash my hands because it's disgusting. Say thank you and have a great rest of your day. If you need anything, I'm going to be right outside. Just use your call light. I'll be right in for you, okay?
When do we cough?
All right, that's all good.